When thinking about the signs and symptoms of liver cirrhosis, don't forget to include labs. So now we're going to take a look at the lab work for a patient with liver cirrhosis. The most obvious lab that we'll see is an increased bilirubin level. And remember that the bilirubin level is not going to be noticeable on this as jaundice until the lab work is above 2.5. The client will also have increased liver enzymes, and those are elevated AST, ALT, and ALP. So those three combined are called your liver function test or your liver enzymes. The LDH will be elevated. LDH is a test for lactic acid. It occurs when there are damaged cells and lactic acid is increased. We'll have increased clotting time, so your PT-INR will be elevated, and that means that it takes longer for the patient to clot. The other thing that may be elevated is ammonia, so increased ammonia levels, and this definitely will be increased when we start to see hepatic encephalopathy. Now I've separated it for the ones that are increased and for the ones that are decreased so that it's easier to learn. So the ones that will be decreased would be a decreased protein, so total protein, a decrease in albumin. Albumin is a marker for how well the nutritional status is going. Low sodium, because the fluid in the body is diluted. It's not necessarily because they don't have enough sodium, it's because they have fluid dilution. Low hemoglobin, hematocrit, red blood cells, and platelets are all going to be low. And the white blood cells will also be low because they're all being stored and swelling inside of the spleen. Now let's look at a little question here. A nurse is caring for a client who has advanced cirrhosis with worsening hepatic encephalopathy. Which of the following is expected assessment finding? Select all that apply. Remember that select all that apply questions become true-false questions. So, which is an expected assessment finding of a client who has cirrhosis and worsening hepatic encephalopathy? Okay, so A, anorexia, B, change in orientation, C, asterexis, D, ascites, or E, vector hepaticus. So the correct answers are B, change in orientation. That would indicate some confusion and memory changes going on. C, asterexis is a flappy tremor that is mainly characterized with hepatic encephalopathy. And the last one, E, vector hepaticus, is only present during very high ammonia levels in hepatic encephalopathy. You may have been tempted to choose also D, but D is just considered in the late signs and symptoms and not necessarily specific to hepatic encephalopathy. So you can have ascites without the other things, so that's why you would not choose D. Next, we're going to discuss nutritional things and fluid and electrolytes for the cirrhosis patient. Looking back on the functions of the liver forms bile and breaks down fat. So if it does not do that correctly, then we're going to have a fat malabsorption. With the fat malabsorption, that means that the bowels are not going to absorb the fat properly because it's not being broken down. So therefore the fat does not get absorbed correctly. And then that will change the color of our stool. So our stool will become white stools, and that's called steatorrhea. It also changes the color of the urine, and the urine will become a tea-colored urine. Since we're having problems with the bile entering into the GI tract to break down the fat, we're also going to see a decreased absorption of the fat-soluble vitamins A, D, E, and K. K, remember, is for clotting. And then there's folic acid and riboflavin. Riboflavin is actually vitamin B12, so they have a hard time absorbing these vitamins. They'll also have an insulin resistance, which leads to hyperglycemia with bouts of low blood sugars. Now, the blood sugars usually go through the portal veins and they get absorbed into the liver and converted into glycogen, and then they're released back into the system as glucose when needed. But since this part of the liver is not working correctly, we're going to see high blood sugars. Sometimes they even develop type 2 diabetes, and then they may have bouts of low blood sugar when the insulin is working correctly. Since these patients are often have anorexia, just not wanting to eat anything, you'll see a weight loss with these patients. So we'll need to get daily weights for them to also assess their fluid retention as well. They'll also have a fluid volume excess, as noted with ascites and dependent edema. That's a sodium and water retention that's going on. They'll also have hyponatremia, which is pseudo-hyponatremia because it's just water dilution from too much fluid dilutes the sodium and makes it appear like the body has low sodium, which in fact it either has a normal sodium level or too much sodium. And these patients are also anemic because their total protein level is down, and they also have low hemoglobin. So that's going to come with the signs and symptoms of anemia as well, fatigue, low expenditure of energy, and those sort of things. Now let's take a look at the special diets that we must have for these patients with cirrhosis. The diet plan for the patient with cirrhosis is a high protein, high calories, high carbohydrates, moderate fat, and a low sodium diet. They'll also give replacement vitamins, and we will instruct the client to have small, frequent meals. However, now, here's where the diet plan changes. If the client develops encephalopathy, that is when the ammonia level increases. We then switch to low protein. So you must remember that part, that if the ammonia level is up, we must decrease the protein in the diet. But do you know how to spot encephalopathy where you could assume the ammonia level is high? So in NCLEX questions, they want to know if you can see that the patient has a change in orientation, a change in their mental status, they've become confused, they're stuporous, they're having memory loss, maybe they have factor hepaticus, or they have some dexterous going on. So these are all signs of high ammonia levels in the body. So you need to know those symptoms, then you can say, oh, well, we should implement this diet change, which would be a low protein diet. Now let's take a look at the medications and treatments for liver cirrhosis. Now, the main thing to know about liver disease and liver cirrhosis is that there is no specific cure. We can only prevent further deterioration and then manage the symptoms that the patient has. Aldactone is a potassium-sparing diuretic that we will give to help relieve some of the ascites and dependent edema. Lactulose will be given to decrease the ammonia. The way lactulose works is it is a laxative and it creates diarrhea. So we expect the patient to have a lot of diarrhea with lactulose. Lactulose is given to help decrease the ammonia level. We will also give antibiotics to help decrease the ammonia level. This works by depleting the intestinal microorganisms, which will decrease the ammonia level. Remember, ammonia is a byproduct of the tiny gut bacteria that we have. Ingerol, also called propranolol, is also given to decrease portal hypertension, which will help with the ascites fluid as well, and with the esophageal varices. Ursodeoxycholic acid is given to help break down fats, especially cholesterol. IV albumin, and remember albumin is a blood product, so this will come from the blood bank. It'll be treated just like a unit of blood, but is albumin. So IV albumin is used to pull the edema back into the vessels. So remember, Mr. Albumin likes to live in the vessels, and Mr. Albumin loves water. So if we give IV albumin in the vessels, it will help pull some of that edema or the fluid that's in the peritoneal cavity and in the tissue spaces back into the vessels. Then it will go circulate back through the portal system, which we've given the Indral to help decrease that pressure so it can go through easier. And then we're going to give the potassium-sparing diuretic to help that flush out through the kidneys. So they all kind of work together. Another thing the patient might get is a platelet transfusion if the platelets become too low. Another thing that some patients will receive is nclex-rn. nclex-rn is a medication given to help alleviate some of the itching from the excess bile salts underneath the skin. Although this medication is helpful, it doesn't always work out as that great. Now we're going to discuss the paracentesis. The paracentesis is done to remove ascites fluid. As a nurse, we should get a pre-weight, place the patient in a semi-Fowler's position. As the physician is doing the procedure and it's finished, we will measure the fluid, document its color, amount, and then send it to the lab for testing, apply a sterile dressing, and obtain a post-weight. Always have the client empty their bladder before any procedure that requires a needle to be inserted into the abdominal cavity. Also make sure to obtain the client's vital signs before, during, and after the procedure. You will want to watch out for complications of this procedure, which would be hypotension from removing too much fluid at one time. So just make sure you monitor how much fluid is being withdrawn and to not cause the patient to go into a hypovolemic shock status.